Okay, let's get started. Hello, everyone, and welcome to the second in our 5-part series on food allergy fundamentals. My name is Marie Malloy. I'm the National Director of Community Engagement at FAIR and your moderator for today's webinar. Before we get started, a few housekeeping items. Today's presentation is being recorded. You will receive information on how to access the recording in 7 to 10 days, so keep an eye on that in your inbox. At the conclusion of this webinar, you will be directed to a survey. If you are requesting continuing education credits, you must fill this out. Certificates will be sent out next week. To make sure we can maintain a quality recording, everyone is muted throughout the presentation. There'll be time for questions at the end of the presentation, and in the meantime, you can submit questions using the Q&A button on your Zoom screen. That also allows you to communicate directly with my FAIR colleagues and myself. Now, without further ado, it's my pleasure to introduce today's presenter, Dr. John James. Dr. James has worked in the field of allergy, asthma, and immunology for over 30 years. He is board certified by the American Board of Allergy and Immunology and has clinical experience in the diagnosis and management of allergic diseases and asthma with a special interest in food allergy and anaphylaxis. A native of Arkansas, he received his undergraduate degree from the University of Arkansas and his medical degree from the University of Tennessee. Dr. James completed his pediatric residency at the University of Utah and his allergy and immunology fellowship at Johns Hopkins University. While working there, he received mentorship and training from Drs. Hugh Sampson and Robert Wood, both noted leaders in the evaluation and management of patients with food allergy. Dr. James was a medical school faculty for 4 years at the University of Arkansas and worked closely with Dr. Wesley Burks, another well-known expert in food allergy field. He then worked with Colorado Allergy and Asthma Center for 24 years before retiring in 2020. He serves on many food allergy-related professional boards, and in 2021 started a medical specialty consulting business called Food Allergy Consulting and Education Services. Phew. I will now turn it over to Dr. James.
Thank you very much, Marie, for that introduction, and thanks for having me in this second webinar of our series on food allergy this year with FAIR. I really enjoyed preparing this and working with the professionals at FAIR. So today we're gonna talk about food allergy diagnosis. The first webinar was on just the general overview of food allergy. So our learning objectives are listed here. Part of the initial part, we will have some review of what I covered in the first webinar. And then we'll go into the history and physical exam, how that plays a role in diagnosis, diagnostic allergy testing, including prick puncture skin testing, in vitro blood testing, and component diagnostic testing, unproven testing for food allergy. I'll discuss that as well. And then we'll spend time on oral food challenges, which are very important in the diagnosis of food allergy. So beginning with an introduction, the body's immune system sees a reaction to food as harmful and reacts by causing symptoms. Food allergy, this is very important, is an adverse reaction to a food mediated by a specific immune response, typically by an Ig-mediated reaction. Common food allergies, as many of you know, include peanut, cow milk, egg, tree nut, shellfish. Allergic reactions can cause adverse symptoms in the skin, the mouth, eyes, the gastrointestinal tract or gut, lungs, heart, and brain. And in some cases, it's a systemic reaction with all of these systems involved called anaphylaxis. Mild and severe symptoms can lead to anaphylactic reactions, which can be life-threatening. We did cover that last time, and we'll mention that in this webinar as well. And finally, a food intolerance is an adverse physiologic response to a food that is not mediated by an immune response. The most common example would be lactose intolerance. And I'm gonna spend some time differentiating food allergy and food intolerance today. I put this cartoon in, it was in the other webinar as well, just to set the stage for what an Ig-mediated or immediate hypersensitivity allergic mechanism would be in a classic food allergy. So if someone becomes sensitized to, let's say, peanut in this case here, that protein, which is processed in the gut, is absorbed through the gut and presented to the immune system. Here we have some special lymphocytes, and they process the allergen and then present it to other lymphocytes that will manufacture or generate allergen-specific IgE molecules, which then are fixed onto the surface of mast cells and basophils. And the mast cells go into tissues. And if you can see here, when you ingest, when an allergic person ingests peanut on a subsequent exposure, then the allergen cross-links or brings those Ig molecules together, activates the mast cell and basophils, and then a whole cascade of mediators are released: histamine, leukotrienes, prostaglandins, and those go to the tissue and cause contraction, bronchospasm, hives, wheezing, coughing, and can cause anaphylaxis in the worst case scenario. So I just put this paradigm up just to set the stage for the classic Ig mediated reactions. This slide depicts the three major types of immunologic or allergic adverse food reactions. Again, food allergies are based on an immune mechanism. To the left, you see the classic Ig mediated reactions, which can cause anaphylaxis, oral allergy syndrome, I'll talk about that later, immediate gastrointestinal symptoms, asthma, rhinitis, hives, and even contact hives on the skin where you come in contact with an allergen. The middle group is the mixed IgE, non-IgE group. And the best example here would be eosinophilic esophagitis. Many of you have heard of this condition. It can cause inflammation in the esophagus, causing strictures, problems swallowing food, food being lodged in the esophagus, pain, gastroesophageal reflux symptoms. Can be a very problematic allergic condition. Other eosinophilic gastroenteropathy, I won't talk about those today, but then atopic dermatitis also falls in this category. This is a form of eczema. You may be exposed to this with family members or children, and this falls into this category as well. There is a subset of atopic dermatitis patients who do have food allergies contributing to their disease. And the last group is the non-Ig mediated or cell-mediated group. And the most common one here would be food protein-induced enterocolitis, FPIES. We'll talk about that later. There's also food protein-induced enteropathy, food protein-induced proctocolitis. Celiac disease falls into this group. It has an immune basis, and dermatitis herpetiformis. So all of these have an immune basis, so they fall into the food allergy grouping. What about the food intolerances? So these are adverse physiologic responses to foods. They are adverse food reactions, but they do not have an immunologic basis or mechanism. So they're broken down into these two groups: toxic or pharmacologic groups like bacterial food poisoning and scromboid poisoning. These patients look all the world at times like a food allergy reaction, but they're not immune-based and they're not classic food allergy. Then there's the non-toxic intolerance group like lactose intolerance, gustatory rhinitis, when people eat certain foods like hot peppers or chilies and they develop all runny nose, congestion, sneezing. It's not an immune-based reaction, it's a physiologic reaction. So this slide, I think, is one of my favorites because it really puts them side by side: food allergy on the left, food intolerance on the right. So again, food allergies, adverse food reaction triggered by an underlying immune mechanism. They must be addressed by specific food avoidance and with allergy medications when needed. They can cause serious life-threatening situations like anaphylaxis, and a classic example would be peanut allergy. On the right, food intolerances, again, adverse physiologic responses to foods without an underlying immunologic mechanism. Again, you have to avoid those foods that cause the reactions, and they're typically adverse digestive symptoms or GI symptoms like nausea, abdominal pain, abdominal gas, bloating, diarrhea. So that's real common with food intolerances, and lactose intolerance we mentioned. So what are the basic facts of food allergy? The public perception of food allergy is 20 to 25%, which is higher than what is actually known and documented with testing and with workups. Approximately 32 million people in the United States have food allergies. Approximately 11% of adults, this is data that has really become available more recently. It's really, we didn't know this many years ago. Almost 8% of children have food allergies and 10% of infants. The prevalence of food allergy we know is higher in people who have atopic or allergic histories. So if they have atopic dermatitis, pollen allergies like hay fever, or asthma, we do see an increased prevalence of food allergy. And the increased prevalence of food allergy has been noticed over the past 2 decades. Definitely been many studies confirming this. And just for an example, peanut allergy has tripled in prevalence over the past 2 decades. That's very striking. So what about prevalence of food allergy in children? The parent-reported prevalence is about 11%. A convincing pediatric prevalence with workups is about 8%, as we said earlier. And then physician-confirmed prevalence is a little less at about 5%. And we mentioned the common foods that are usually seen in classic food allergies: peanut, cow milk, tree nuts, shellfish, and egg. And also there's disparities in food allergy as in asthma and other conditions, with prevalence higher in Black and Hispanic children. And food allergies in adults, about 1 in 10 or 11%, we said earlier, 26 million adults. Peanut allergies affect over 4.6 million adults. This last bullet is really, I find interesting. About half of food allergic adults report the onset of food allergy in adulthood. So they had no food allergies when they were infants, children, adolescents, young adults. So these are actually coming on or originating in the adult years. I used to see this a lot in Baltimore when I did my fellowship with people developing shellfish allergies, because there was a real common part of the diet there. These guys would come in and were upset because they had eaten this all their life, and all of a sudden they developed a shellfish allergy. Okay, so the stepped approach to food allergy diagnosis is listed here. I'm going to go through these in the webinar. A thorough clinical history is imperative and extremely helpful in the workup. That's really the most important step of all that we'll talk about. Decide on specific testing if clinically indicated. So we don't want people to just be doing testing randomly and do lots of screening tests without doing other initial workup. Types of testing: skin prick testing, serum, the SIGE means the serum blood testing for IgE, and the component diagnostic testing. Arranging oral food challenges if needed and if clinically indicated. And avoiding use of unproven, non-validated testing for food allergy. So again, the most important single test for starting the diagnosis of food allergy is a thorough, detailed clinical history. And this should entail these things. There should be signs and symptoms elicited in the history, like skin symptoms, hives, swelling, eczema, GI symptoms, nausea, vomiting, diarrhea, abdominal bloating and cramping, respiratory symptoms like cough, laryngeal edema or tightening in the throat, wheezing, chest tightness, shortness of breath, and then anaphylactic symptoms, which would really be even taken a step further, like problems with the cardiovascular system, low blood pressure, fainting, poor perfusion, turning very pale, and even the respiratory symptoms becoming more severe, like really tight larynx or throat and tightening in the chest. So then the timing of the reaction is important, because most of the time the reactions occur within 0 time up to about 2 hours. Most of them even earlier than that. So the timing is important following that food ingestion. The amount of food ingestion is something we ask in the history. Was it raw? Was it cooked? How was it prepared? And the ability, what's the reproducibility of the reaction? Sometimes parents come in and say, oh, it's happened 3 or 4 times and the symptoms are exactly the same each time, or maybe with the different episodes, they were totally different, and it just doesn't really fit the pattern of a food allergy. And then what treatment was required? Was it just antihistamine? Was it no treatment? Were there antihistamines? Were there epinephrine given? And what was the outcome? So other key features of the clinical history, the epidemiology of food allergy. We want to know, well, how, we know some foods are more common than others. What is the prevalence of peanut allergy, cow milk allergy, sesame allergy, and other foods? So we're going to use that as a guide too, to say, oh, this is a more likely reaction. What are the factors that could have occurred around the reaction, like exercise, use of certain medications like non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, ingestion of alcohol? Was there an illness, a viral illness? Was there any other factors that may have contributed or lowered the threshold for a reaction that really contributed? And is it a condition that's mimicking food allergy? We talked about food intolerances. Well, certainly that's something we need to discriminate in our history, because it could have been a food poisoning. It could have been a gustatory rhinitis we mentioned, or some contact condition that's really not an Ig-mediated reaction. A physical exam needs to be done, but it's looking for other conditions that may not be food allergy. It doesn't always guide us to a specific food allergy diagnosis. And the general mechanisms I covered earlier, there's allergy versus intolerance. There's the IgE versus the non-Ig mediated reactions like FPIEs, and then the mixed IgE, non-IgE reactions like eosinophilic esophagitis, or a lot of people call this EOE. You may have heard that or seen that in your reading about food allergies. So I'm doing a few cases this time in this webinar. This one's a 6-month-old female who had persistent and difficult to manage eczema or atopic dermatitis beginning at 1 month of age. Otherwise, she was well and thriving. She was breastfed exclusively until 4 months of age, when a few solids were introduced: rice cereal, selected fruits, banana, and applesauce. Egg was introduced at 5 months of age, a scrambled egg, and she developed vomiting within 1 hour and some redness around her mouth, but no treatment was needed. It all resolved on its own. And they didn't give egg for a month, and then reintroduced it a month later, 6 months, and she developed significant and immediate vomiting, irritability. Her eczema flared significantly, and she was treated with antihistamines, and the egg was discontinued at that point. So this is, I think, a common case scenario we would see in the allergy clinic. Should allergy testing be performed? I would say yes in this case, based on the history, based on the suspicion the egg is very likely an allergy in this infant, and it would be good to confirm that for the family, to develop the appropriate elimination diet, and then discuss what to do in the future, the natural history and how long this would last. Could it be resolved? So that's just pulled that one for an Ig-mediated reaction for you. So now we're going to move into diagnosing food allergy testing. So if the clinical history is very consistent and suggestive of food allergy, then allergy testing, diagnostic allergy testing, should be performed for a number of reasons: to confirm the allergy, to give the parents good advice if there needs to be elimination diets and what to do about the future. Does anything else need to be investigated? So the 3 types of testing we're going to talk about today: skin testing, which is in the upper left-hand corner. That's just one picture I had. Just many of you are familiar with skin testing, but I wanted to put that picture there. The second is blood testing, and then oral food challenges. And then we'll talk about the unproven testing. So diagnostic allergy testing, key points. Skin prick testing options include testing with commercially available food extracts. So these are extracts we purchase from manufacturers that are quality controlled, and this is done very commonly in allergy offices. Or extracts of fresh food. Sometimes we use those in the pollen food syndrome or oral allergy syndrome, and I'll mention that in a case scenario. There's immunoassays, blood testing to whole food extracts, and then component immunoassays to specific food proteins. I'll spend time on that. So prick puncture tests are very reproducible and less costly than in vitro blood testing. That's the blood testing. There's minimal patient discomfort. There is a prick, there's on the skin, and they're safely performed in an allergist's office, and they definitely should be performed in an allergist's office because there occasionally, very rarely, there can be a reaction to testing, even anaphylaxis. So it needs to be done in an office that is equipped to perform the testing and to manage reactions if they do occur. Certain medications, such as antihistamines, need to be held for 5 to 7 days before testing is performed. So that's a very important factor, so you don't get negative responses because of the medications. Moving on to blood testing, these are immunoassays to identify food-specific IgG antibodies in the serum. They're widely available. They can be useful, and sometimes patients can't be skin tested. They have really bad eczema. They are on medications they can't come off of. So blood testing can be a great alternative to skin testing. And sometimes we'll use them in together. I'll talk about that on a table in a minute. They are reproducible, but they do cost more than skin testing. There's some minimal discomfort with the blood draw. They're done in a laboratory, and so the patient they could be drawn in an allergist office if they have a lab, but most people have to go to a standard lab to have these drawn with an order. And the medications, like antihistamines, they do not impact the results. So to summarize here, diagnostic allergy testing, a positive test, I didn't mention this earlier, but I want to stress this now. A positive skin test does not always indicate clinical allergy. There can be false positive reactions, meaning that you can have a positive skin test, but it doesn't equal a true allergy. It's because these tests have low specificity, meaning they can have false positive reactions. On the flip side of that, a negative skin test is very helpful in ruling out a food allergy because these tests are highly sensitive. They don't have, the false negative rate is very low. So testing is not required for diagnosis in a patient with a clear IG-mediated reaction when there's, say, anaphylaxis to a single food. If the history is clear cut that they have had an anaphylactic reaction to, say, a walnut or a cashew with major clinical symptoms and the time frame fit, and they were treated with epinephrine and ER, well, we don't always do a skin test because the history is so compelling. Avoid testing in most patients without a history consistent with an IG-mediated reaction. I mentioned this earlier, we don't want to just randomly be testing people if there's some mild concern, because you can get false positive reactions. You really need to put it all together. History, what happened with the treatment, and your suspicion, is it in the realm of an IG-mediated food allergy? If a patient is tolerating a food without immediate symptoms, the food should not be eliminated from the diet solely because of a positive skin test. And that's kind of the point at the very top there. So there's a lot in on this slide, but it's really the crux of what your allergist or your specialist who's dealing with allergies should really be clear with you and your family members that this is so important about skin testing and the blood testing. So a positive skin test or food-specific IG in the blood indicates the presence of the IG antibody, like I showed in that cartoon, but it does not always mean there's a true allergy or clinical reactivity. Very sensitive, so it helps to rule out, as I said, but the specificity is not as good. So you have to deal with those false positives, and that we'll talk about that with food challenges, how we take those steps. I do want to mention larger skin tests, wheal sizes, and the wheal is the bump on the skin that's measured in 2 dimensions. That's called a wheal, W-H-E-A-L. And higher serum IG levels correlate with increased likelihood of reaction, but not always with severity. Negative skin tests, they help to rule out allergic sensitivities. And that's what I mentioned earlier with the sensitivity of the test being so good. So if we're going to walk down this diagnostic path of food allergy, we certainly we're suspecting reaction, getting a great history, and then if it's indicated, we're being selective in allergy testing to foods. We don't want to do broad panels, just shotgun approach. That happens. People, they'll just get these hundreds of tests, and there was no thought really in there about how you discriminate about what you were going to test or not. We want to go after the ones that are more prevalent, but don't want to be just randomly testing foods. There are false positives. That's why I said earlier, again, that could impact what happened with food elimination, what would happen with anxiety about food allergy when there's really not one. So that's so important. Then sometimes we test with fresh foods, because in the pollen food or oral allergy syndrome, when you test with commercial extracts, they sometimes are not stable enough. We have to use like fresh apple or fresh, some of the fresh form of fruit, peaches or something, to do the test on the skin with fresh. That's called a fresh food prick by prick testing. You may be familiar with that with your allergist. If you suspect the non-IG mediated reactions, like the food protein induced proctocolitis, then biopsies of the gut may need to be done by a gastroenterologist. And then in the lactose intolerance, I put hydrogen breath test, sweat test is for cystic fibrosis, endoscopy is used in eosinophilic esophagitis. So here's a scenario: a 40-year-old man in general good health until last year, when he noticed increased abdominal bloating and gas with diarrhea. He stated that symptoms occur within a few hours after ingesting a variety of dairy products, such as cow milk, cottage cheese, and ice cream. He can tolerate small amounts of dairy products without symptoms. So this comes to the clinic a lot too. And would this patient need testing? Well, a lot of times I can tell you they do get tested, but if you can really focus on the history and tease it out, then you can, this scenario would fit very commonly with lactose intolerance. This being that mainly GI, gastrointestinal symptoms, like I stated earlier, it occurs hours after the ingestion, and small amounts of it can be tolerated without symptoms. There's usually a threshold that has to be reached to trigger symptoms. So this would be lactose intolerance, and testing would not need to be done. And the hydrogen breath test is the gold standard diagnostic test for confirming lactose intolerance. So food allergy testing, we talked about the sensitivity and specificity. I already mentioned that, but the wheel size I want to mention again, because this is something that really occurred after my fellowship, and I started learning about this in clinical practice, and studies were done. So the wheel sizes are important. That's why your allergist would be measuring the size of these wheels on the skin. The wheel, not the redness around it, but the wheel is most important. And they can be helpful in increasing the likelihood it's an allergy and sometimes severity. And again, if you just have positive tests without doing histories and such, you're going to see more than what are truly diagnosed down the road. Don't do panel testing, and fewer than 30% of pediatricians, family practice physicians feel comfortable interpreting these lab tests to diagnose food allergy. So they may be ordering a lot of these tests, but then what ends up happening all the times is they'll refer the patient to an allergist. So sometimes it might be better just get their history, and instead of just doing a bunch of random testing, to go ahead and make the referral, because it might mean less testing is needed and a more focused diagnostic path is undertaken. So I know this table is kind of busy, but I wanted to, it will help to in later slides. This is called the predictive value of food-specific IgE, either by blood or by skin testing, and how it would fit and help with saying what is the likelihood this is a positive, this patient would have a positive reaction upon ingestion. So this column here is 95% positive predictive value, and this is 50%. So likelihood. So let's just take peanut, for example. So peanut, a serum IgE, if it's greater than 14, and that's kilounits per liter, that's a 95% chance that patient is going to react after ingesting peanut. And in addition, the skin test here, I have greater than 8 millimeter wheal. So those two are important. If those two are both there, then it's the about 95% chance that that patient is going to react upon ingestion. So sometimes doing these tests can be, with the history, doing the selective testing can be very helpful to say, okay, we don't need to do a challenge. We need to eliminate, we need to be careful, we need to reassess this in a year or two. On the other side here, the 50%, what's the likelihood they would be negative? Well, if the peanut IgE is less than 2 and there's a positive reaction, or the skin test is less than 3 millimeters, this is the group of patients who are more likely to not react. So it can be helpful in deciding when would we want to do a food challenge or when would we not want to do a food challenge. We're trying to risk benefit, share decision making with the family. The other ones are similar. I won't go through those because of time, but we know this data for peanut, milk, egg, and fish. And other foods are being worked on, but the data is just not as reliable at this point. So we'll start to see more of this fill in with time. So what about cross-sensitization among foods and pollens? Well, we might see positive skin tests to related foods, but there's no clinical relativity in those things. And this will come up in some of the oral allergy syndrome or pollen food syndrome. So there may be similar proteins in legumes such as soy, garbanzo bean, chickpea, pea, and they can have positive skin tests to multiple legumes, but when those patients undergo oral challenges, they may react to only 1 or 2 of those legumes. And the problem is we're picking up specific IgE to proteins that are in these legumes, but they're all not clinically relevant and don't trigger an allergic reaction. The other scenario will be sensitization to pollen. So the oral allergy syndrome, better known as pollen food syndrome. The big example is birch pollen. You'll see this is birch tree pollen in a patient who has hay fever, and you'll see that they can have positive skin test results to multiple foods like peanut, almond, hazelnut, a variety of pitted fruits like apple and peach, and even vegetables, celery. So, and I'll go over that in a little more detail too, because I think many of you have probably seen this, or you may have experienced this yourself. So it's good to know what is pollen food syndrome. This is a case. So a 15-year-old male with a 4-year history of mild allergic rhinitis, controlled with nasal steroids and as needed Zyrtec. Over the past year, he has had mild itching of his lips and tongue and the roof of his mouth, but really no other symptoms. But later has had itching and tightening in his throat, without other symptoms. So his symptoms really involve mild itching of his lips, tongue, roof of the mouth, and then some itching of his throat, but no other symptoms. And he specifically has noticed these symptoms after eating fresh apples and peaches, as well as hazelnuts. He's never had to treat, other than treating his allergic rhinitis, he just avoids those foods. He just basically avoids the foods that he has had symptoms with. So this is an issue where it can be very helpful to, if the patient's coming in for an allergic rhinitis workup, maybe they're on allergy shots, but then they're noticing these symptoms, to try to help identify which fruits, vegetables, tree nuts would be a consideration to avoid or completely restrict. These reactions usually do not go on to a systemic reaction. I need to mention that too. They usually are localized to the mouth and throat. Now, the molecular diagnosis of food allergy, component testing. This is to identify major allergens in certain foods. In peanut, there's these storage proteins. These designations are not really important necessary for this talk, but RH1, 2, 3, and 6 are the ones that are important. And you may know that RH2 is very important and RH6. These are really accurate in diagnosing peanut allergy. In birch tree pollen, there's this BET-B1, and it can cross-react with allergens in peanut and hazelnut. We mentioned that on the previous slide. And hazelnut can cross-react with other foods. So these proteins are used now in diagnostic testing. So IgE bindings to specific proteins in foods might provide a more specific diagnostic information than other tests, like the standard skin test. I mentioned RH2 and RH6. These have been studied extensively and have been used clinically and in research settings. The RH8 is cross-reacts with the birch pollen, and say a patient has birch pollen allergy and they have RH8, they have a positive peanut skin test, but they say, oh, I eat peanut all the time, I've never had trouble. Well, we don't, just because they have a positive skin test, in that patient, we don't want to restrict peanut. But if they've had clinical symptoms, it's more likely that they have a cross-reaction to these proteins here and not RH8. So if there's undetectable IgE to these peanut proteins and an isolated positive to RH8, this would suggest a tolerance to peanut. And increasing concentrations of specific IgE to RH2 is associated with allergy to peanut and maybe increased risk. Other types of testing, we don't do intradermal skin testing. This is under the skin testing. It doesn't add to the diagnosis, and there can be a risk of reactions, even systemic reactions. Atopy patch testing is like doing testing for contact delayed reactions, like to nickel or to other cosmetics on the back. It's a little patch. It's put on the skin. It was used in eosinophilic esophagitis, still used in some clinics, but it hasn't been really standardized, and application methods and interpretation or can be difficult. So this is not a type of testing we usually use for immediate or IgE-mediated food allergy. So what about the other tests you may have heard of? Well, I put the one at the top is food-specific IgG and IgG4 testing. This testing is done commonly. I used to see this all the time in clinic, and there would be hundreds of these tests done to foods. And the issue is IgG is not an abnormal response to food. If you were ingesting a variety of foods in the gut, IgG can be made as a normal response. So if I did my blood to say a panel of 100, I'm going to see IgG to a variety of foods that I'm eating regularly in my diet with no adverse symptoms. And so the problem here I see is that you get a lot of positive results, and foods start to get eliminated from the diet. It can then be multiple foods eliminated from the diet without really confirming that it is a true food allergy. And this can be a problem, especially for infants and children, if they really need to have good, well-balanced diets. So that's one type of testing you might have seen. There's total serum IgE measurements. This is done in asthma and eczema, but they don't really add it. We know that allergic people can have high IgE levels, but they don't correlate to specific food allergy or an eczema type of trigger. Other unproven methods are sublingual, so under the tongue, or intradermal provocation, lymphocyte activation or cytotoxic testing. I used to see this not as often, but it's a laboratory test done on lymphocytes incubated with food allergens and looking at the morphology of cells, but these have not been validated or proven as a method to diagnose food allergy. And then kinesiology and electrodermal testing. So I listed these. You may be familiar with them or have heard of them, and they're not validated with good controlled studies. So elimination diets are most useful for chronic conditions like atopic dermatitis and GI syndromes, eliminate the food or prescribe limited few food diet or an elemental free amino acid diet. This can be extremely, it's just amino acids, no peptides or large proteins. And there are formulas that are available to do this. So elimination diets are used, but the oral food challenge is really what I'll spend the last part of the talk on. Physician supervised or people who are trained to do this, having medications immediately available if there's reactions and equipment if there's an anaphylactic reaction. This is just this has to be done. You have to be prepared because reactions can occur, and we don't just randomly do food challenges. We have a stepwise approach to get there, as I mentioned earlier. Open challenges are done most commonly in practice. So the physician or the healthcare provider, the parent, the patient, they all know what the food is. So it's peanut, milk. It's not blinded in any way. Double-blind challenges are done in research settings where the physician and the patient, parent don't know if it's a placebo or active food. So we usually offer food challenges when the odds of tolerating the food based on history and other tests are reasonably thought to be they're going to be a negative challenge. It is safe. It must be done in a safe setting, as I mentioned. Standard procedures are done in preparation before with the family, risk and benefits discussed. What's the food going to be? Frequency of the buildup. How are they observed and examined during the challenge? And what happens if there's a reaction? Because they can occur, and that's why we do them in the office. They can be time consuming, they can be resource intensive, and they do carry risk of a systemic reaction. So we have to do that shared decision making with the family about what we need to know. And sometimes it's so critical that we do the challenge because they may have outgrown that food allergy, and that changes their life considerably. And sometimes parents will decline the food challenge just because of the risk, or they don't know if it's going to be a benefit. So if testing for food IG, if it's negative, then, well, like I said, food skin testing, if it's a negative test, it's very reliable, then we can reintroduce the food unless there's a convincing history that would warrant doing an oral food challenge first. So that happens sometimes. We're not quite, we're nervous. We're not quite sure we want to just introduce it at home. So we can always do that in the office. That's always a great option. And everyone feels more comfortable that we're going to do it under observation and make sure that it truly is negative. If skin testing and the other type of testing is positive, well, we do food avoidance. And if the elimination, if there's no resolution with an elimination diet, we will reintroduce the food unless there's some other reason that we're convinced that there could be a reaction. We don't want to keep the elimination diet going if there's not a good reason. And we can see if there's resolution with an open challenge in the office and a double-blind placebo control, which removes all bias in that process. So this is a last case, a 3-year-old male with a past history of allergy to cow milk. He had past symptoms of hives on his face, vomiting, and a cough. His last reaction was about 1 year ago with vomiting. He had an accidental ingestion of cow milk at 2 years of age with a mild rash on the face. So he's coming back in for a reassessment. A kid who has milk allergy, this is the perfect scenario to retest and think about doing a challenge. The skin test was positive, but it was right at the positive level, 3 millimeter wheal. That's right at when a test becomes positive. And the blood test was 4 kilounits per liter, which is less than what we would typically see for milk. And so so we were all interested in doing an oral food challenge to see if this child had developed tolerance. And it certainly would be benefit if the parents are agreeable. The risk benefits would be in the favor of the patient. And we would do that as an oral food challenge in the office, as I mentioned. So then this is just a standard buildup of an oral challenge. This is not too important to bring up to cover today. It just talks about this is the dosing, how we break it down at the different levels, and what the final dose would be. This is FPI, so a young infant who was initially breastfed, supplemented with cow milk formula, frequent episodes of delayed vomiting hours after the ingestion. Went to the ER once, was very dehydrated, lethargic, was having poor weight gain. Formula was stopped at 5 months of age and symptoms resolved. Cow milk was reintroduced at 1 year of age, and 2 hours after ingestion had the same reaction, repetitive vomiting, lethargy, went to the emergency room for evaluation and management. This is just an overview of what FPIES would look like. It's not an IG-mediated reaction, so we don't do standard testing, but occasionally we'll do a modified oral food challenge for these patients to confirm. And this, it doesn't just happen with cow milk, it can happen with grains and soy. And I didn't do a lot of these in clinic, but sometimes it was critical to see if they outgrew it, because some of these patients, a majority of them outgrow it, and we have to do the challenge, say at 4 years of age or 5 years of age, so the family knows it did resolve. You have to keep them in the office longer because it's a delayed reaction, and the dosing is different from a standard challenge. You give them the food right at the beginning, and you just wait and see if you don't have to do 6 doses like we do with the standard food challenge. So let's see, for non-IG mediated disorders, elimination diets we discussed, food challenges, ancillary testing like endoscopies and EOE or eosinophilic esophagitis, biopsies in some of the food protein induced enteropathy cases. So reasons for referral: if there's a known diagnosis of food allergy, for ongoing management and follow-up to see if tolerance develops. When a food-specific IG level is undetectable, but a child has a convincing history of an immediate reaction, maybe even anaphylaxis. So that's a good referral. When food IG levels indicate sensitization prior to the food being introduced, and this is happening now in cases of early introduction of foods, and this is actually a whole nother webinar we're going to discuss in the future. Known diagnosis of food allergy with increased risk for other food allergies. So if a child has egg allergy, what sometimes parents want to assess for other food allergies. When an infant develops eczema that's not responding to treatment or experiences a reaction to a specific food, that's a good referral. You may have a family that has a previous child with a significant food allergy, and what do we do with the next child that in the family? Evaluation of possible food allergens and eosinophilic esophagitis. So these are good reasons for referral. And they're not the only reasons, but those are kind of the general ones. For what's the role of the allergist? Well, as I said, really doing that history, doing the basic steps for diagnosis, doing proper diagnosis and elimination when needed, and developing a good action plan for the family. When is an elimination diet needed, and how is that done? Using nutritionists to help do that with the allergist. What's the treatment plan? When is epinephrine going to be used? When does you need to go to the emergency room? All those things should be talked about. And when is the follow-up needed? When would you do retests? When would you think about doing another challenge to see if tolerance has developed? And if there's been any new allergies that develop, you need to come back and start that process again. And being a resource, not only for the patient, families, but for schools, communities, and primary care physicians. So basically, we've covered everything I wanted to. I hope that's a good overview, and I've tried to leave time for questions, and I think we have some time. So I'll turn it back over to you, Marie.
Thank you, Dr. James. We got a ton of questions, lots of good questions, and I'll try to summarize some of them so we can get to them. But since we just talked about oral food challenges, there were a couple of questions about what's a good age for an oral food challenge? How young is too young? Is there a baseline? Can you talk a little bit about age?
That's a great question, and it amazes me that we were able to do challenges even on infants down to say 6 months, but especially since you may have heard about all these new oral immunotherapy protocols. mainly to peanut, but there's allergists all over the country that are doing it to other foods. So what they like to do is make sure they have to confirm, does that infant or child have the allergy? You don't want to be putting them on oral immunotherapy. So unless they really need it. So I would say it's not, generally we were doing challenges over 1, 2 in that range, but sometimes we're doing them. You can definitely do it. It's maybe harder because of getting the food in, what preparation of food will that infant take, but it can be done. It certainly can be done, but more commonly, I would say in older infants and children and young adults and adults.
Great, thank you. We had a few questions about how food allergy testing may be influenced or impacted by such things as illness, immunocompromised diseases, exercise, different things like that. If somebody's ill and then they go to get testing for food allergies or NSAIDs, if they're taking them, do they play a role in impacting some of the results of a test?
That's a wonderful question, and I think I think about how I put that in the talk. What those cofactors do is really contribute to a type of reaction a patient would have. Like if they have a reaction with exercise and food allergy, the exercise can lower the threshold for a reaction. A viral illness can lower the threshold for a reaction. A medication, non-steroidal can. They don't specifically impact the skin testing unless you're taking other medications like antihistamines or antidepressants, or those medications can make false negatives be more common. So those factors really, the way it should be in the talk, is impacting the reaction itself. So, and when people are on oral immunotherapy to peanut, it's really clear cut in the protocols. If they're having an illness like that, they need to talk to their allergist and maybe cut back on the dose. That's extremely important. Very great question.
Thank you. A couple questions about if you have a skin test that says one story and a blood test that tells a different story, which do you weigh more, if at all?
That one table I have, I think it's going to be filled in more with time, and that's where it becomes very useful. I typically have relied more on skin testing data, like the wheel size to peanut, egg, milk, sesame, those things, tree nuts. That's been my bias. I lean because that has been the gold standard for so long. But the blood testing is becoming more reliable. Especially those the component testing and some of the newer testing that's being developed, and that's gonna shift. I think they're both good. I like to use both of them in my decision if I have them available with the history. But if I think skin testing, I would have typically done that, put more of my confidence in that. Then that's changing with time as the new blood testing validations being done.
Great. That's a great segue into, we had questions about epitope and basophil testing. What's on the horizon there? Maybe just a quick, summary of what it is in the 5 minutes we have left.
We kind of thought this might come up, so I wanted to. Basophil activation testing, BAT. When I was in training and early in my practice, this was absolutely only done in hardcore research settings. It has become more commonly used in some of the research trials done around the country, where they want to use this as an activation marker for, say, certain types of food allergy. So it's a blood draw. It has probably a better specificity than skin testing, fewer false positives. It is looking at the activation of these basophils, and I mentioned that in that cartoon. They have certain markers on there. If there's a reaction, an allergic reaction, these cells are upregulated. That can be measured in the lab, and they're trying to bring this into more of the clinical arena. It's expensive. It may not be available in most places, but this is definitely going to be something that is going to be what they call a biomarker for food allergy reactions. And the second one was the the epitope pattern microarray analysis. And this again is going to be something that you're going to hear about more and more. I'm hearing more and more about it, and I'm interested to read more about it because it's coming to the forefront. And it's looking at really the basic, not a protein, it's like that we talked about earlier with components. These are the components of the allergenic part of peanut or milk, right? The very smallest parts that the antibodies react to, and trying to distinguish which epitopes are going to be highly likely to cause a reaction, moderately likely, or less likely to cause a reaction. These will be, these kind of tests will be useful to clinicians and also to families and patients. But I think at this point we have to stay tuned for more information to see how the technology develops and when will it become clinically useful and available.
Great. One more question. A couple of people asked to clarify the sensitivity of the test again. It seemed there was a low risk of false negatives and a high risk of false positives. Is that correct?
Okay, so let's do sensitivity first, because I think this is probably how it should start always. So a sensitivity is a test where you're looking for the positivity to be, you do a skin test of peanut. If it's positive, you want that to be, you want that to help you clinically and for the patient. So it's looking at positive, but you can get false negative. So a patient has peanut allergy and you do a skin test and it's negative. Well, that's a false negative. So you want their false negative rate to be extremely low, so you don't miss a positive peanut patient. So that's why skin test is great, because they are sensitive. If it's negative, we have pretty good confidence that that patient does not have a peanut allergy. Specificity is looking more at the false positivity rate. So I don't want those, that can get kind of brought together, but I think looking at them separately is probably the better way. So unfortunately, skin tests, the specificity is not as good as we'd like it to be because we have false positives. A patient gets skin tested, positive peanut, but they're not allergic. Well, that can lead to a lot of elimination and all kind of anxiety and stuff. So that's where the food challenges become so important to really make more of a gold standard diagnosis.
Well, thank you. So it's 1:59. This was a great and educational webinar. We had so many questions. Unfortunately, we can't get to everyone, but hopefully people will be able to look at this again in a couple of weeks when it's online and review again. And I just want to say thank you, Dr. James. We really appreciate it. He'll be back in July. A date to be determined to do a webinar on anaphylaxis. I know people had questions about anaphylaxis, and we'll be able to do that in July. Thank you, everybody. When I end this, you will get a survey. If you are looking for continuing education credits, you need to fill out the survey and they will be sent out next week. Everyone who registered will get an email next week about how they can access this webinar again in our learning management system, Food Allergy Academy. So thank you very much. Goodbye, everyone.